on the risk stratification in ASD. Dr. Jose is a training officer in the Department of Anesthesiology at UPPGH, an associate professor 3 at the University of the Philippines, Manila, an active consultant and chief of section of neuroanesthesia in the Department of Anesthesiology, UPPGH. He's also an active consultant at the Department of Anesthesiology in Makati Medical Center and a consultant at the Department of Anesthesiology at Manila Doctors Hospital. Please welcome Dr. Geraldine Raphaela Jose.
Good day, everyone. Thank you very much for this kind invitation to speak about ankylosing spondylitis of the spine, risk stratification, and anesthetic considerations. So the objective of this session is for the participant to be able to understand the consequences of the disease process in the preparation for a surgical intervention from the anesthesiology standpoint, know the risk stratification that are considered in the decision on the anesthetic approach to management, identify the medications that may or may not be continued prior and during the procedure, and recommendations in preoperative planning. So what are the key features of an ankylosing spondylitis? It is a chronic, progressive inflammatory disease involving articulations of the spine and adjacent tissues. It is very common in males with high proportion carrying tissue-type antigen HLA-B27. Diagnosis is made clinically. Uniform development of widespread annular fibrous ossification can be noted, which involves the joint cartilage and the disc spaces of the axial skeleton with eventual ankylosis. The most frequent type of seronegative spondyloarthropathy, which mainly involves the axial spine. Advanced cases, the chronic inflammatory process can cause fibrosis and calcification, which leads to loss of flexibility and fusion of the vertebra resembling a bamboo with a fixed posture, generally known as a chin-on-chest deformation. So this is a typical image of a patient with ankylosing spondylitis. This is the patient's posture. As we know, there is loss of normal curvature at the lumbar spine as compared to an S-curve of the normal lumbar lordosis. Also, as you can see in the neck area, there is an exaggeration of flexion of the neck, cervical neck, which may have anesthetic consequences. So the formation of bone bridges is largely responsible for the classic radiographic appearance of the bamboo spine of end-stage ankylosing spondylitis. Arthritis and ankylosis may develop in the hips, shoulders, and costovertebral joints with or without extra-articular complications. The common organs affected by ankylosing spondylitis are the heart, the lungs, the colon, and the kidneys, but in terms of neurologic involvement, it is quite rare. The functional limitations of this particular deformity are significant. Patients are unable to look forward, make visual contact, and have difficulty eating. These factors, with typically concomitant osteoporosis, will significantly increase the risk of spinal injury with severe instability, deformity, and most importantly, deteriorating neurologic function or paralysis requiring spinal surgery. So what are the indications for surgical spinal intervention? And these are as follows: uncontrolled, severe, and continuous back and neck pain, deteriorating neurological deficit caused by spinal deformity, unstable spinal fracture, inability to hold the head up and see horizontally, and also serious difficulties in eating and drinking because of the spinal deformity. So in terms of surgical intervention, this is related to a greater risk in terms of complications, such as difficult intubation with necessity of awake fiber optic intubation, infection, need for blood transfusions, respiratory and cardiac problems, and renal dysfunction post-operatively. So these are the issues that the anesthesiologists need to address prior to the surgical procedure. assessment of medical comorbidities, association with both the disease and the treatment of ankylosing spondylitis is an important component of the medical clearance before surgery. In terms of cardiovascular concerns, according to the American Heart Association and American College of Cardiology, cardiac risk assessing guidelines in preoperative surgical preparation of patients with AS, cardiovascular disease is advanced if functional capacity is not reached to a minimum of 4 metabolic equivalents. These patients with poor functional capacity of less than 4 mets are at greater risk cardiac-wise. So what do you mean by metabolic equivalence? It actually is an expression of functional capacity. It can be used as a reliable predictor of future cardiac events. 1 MET is defined as the amount of oxygen consumed while sitting at rest and is equal to 3.5 mL of oxygen per kilogram body weight per minute, where 1 MET is resting or basal oxygen consumption of a 40-year-old 70-kilogram person. In terms of functional capacity, it is actually classified as excellent if it's more than 10 METs, good if it's 10 METs, moderate from 4 to 6 METs, and poor if it's less than 4 METs. So in terms of cardiovascular risk stratification, there's an article that came out in 2018 that lateral lumbar radiography may be useful in detecting high cardiovascular risk indices for patients with ankylosing spondylitis. AS is found to be associated with increased cardiovascular disease involvement. CV events can be prevented by early identification of patients at high risk who can benefit from appropriate primary prevention measures. Systematic coronary risk evaluation, also known as SCORE, is the predictive model being used in Europe. But what is noted here is that it underestimates the cardiovascular risk index in patients with ankylosing spondylitis. Cardiovascular risk is calculated according to the total cholesterol systemic coronary risk evaluation score, which is known as TC score. So with lateral lumbar radiography, it actually showed a sensitivity to detect subclinical atherosclerosis of around 72.7% of patients with moderate TC score. In terms of pulmonary concerns, significant spinal deformity in AS can result in restrictive respiratory physiology with notable decreases in vital lung capacity. This may make ventilation during surgery very challenging, especially when a patient is put in the prone position. And for those patients, aggressive pulmonary hygiene in the postoperative period can be and must be encouraged. In terms of neuromuscular concerns, a thorough physical examination should be performed to document any preoperative sensory or motor deficits, especially in patients undergoing spinal surgery. Notation of any motor weakness is important as this may affect the plan for intraoperative neuromonitoring as well as the anesthetic approach to induction of anesthesia. Those patients who have pre-existing motor weakness, we normally do an awake fiber optic intubation in order to avoid further deterioration of the motor deficits that may arise during the procedure. In terms of renal concerns, since ankylosing spondylitis patients receive non-steroidal anti-inflammatory drugs for a long period, interstitial nephritis may be present due to its use. Advanced AS may be associated with chronic kidney dysfunction due to amyloidosis, IgA nephropathy, and tubulointerstitial nephritis. In terms of bone loss concerns, taking into consideration that osteoporosis is a common complication of ankylosing spondylitis with an incidence between 18.7% and 62%, all patients undergoing spinal surgery should be treated before and after surgery for osteoporosis. In terms of the assessment of spondyloarthritis, International Society, European League Against Rheumatism, they have several suggestions regarding the management of ankylosing spondylitis. NSAIDs are considered the first-line drug treatment. And to prevent further progression of the disease and achieve remission with improved quality of life, disease-modifying anti-rheumatic drugs, also called DMARD, are required. They can be synthetic, such as sulfasalazine, and biological, such as anti-TNF alpha agents. So in terms of surgical preparation, it is important to take into account the need for chronic therapy and associated side effects of those drugs. For patients undergoing surgery, they need dose adjustment. In terms of NSAIDs, the perioperative use of NSAIDs or aspirin may be associated with bleeding complications. This is because NSAIDs induce inhibition of COX-1 with reduction of thromboxane A2, which in turn will decrease vasoconstriction and platelet aggregation and increase the bleeding time subsequently. This effect is reversed only after drug withdrawal. Considering the average half-life of an NSAID, they must be withdrawn at some point prior to surgery. In patients whose cardiovascular risk exceeds the intraoperative benefits, for example, patients with cardiac stents, it is recommended to continue the aspirin during the perioperative period. In such situations, the surgeons must be alerted and prepared for bleeding during surgery, even though cardiac doses of aspirin in general are not associated with a significant risk of bleeding. Since COX-2 inhibitors have little effect on platelet function, there is no need to suspend them during the perioperative period. However, this group of drugs is associated with risk of significant cardiovascular adverse outcomes. In terms of glucocorticoids, patients continuously taking glucocorticoids are at risk of intraoperative hemodynamic instability and postoperative infection. A few small randomized controlled trials and systematic reviews demonstrate that there are no significant hemodynamic changes between patients receiving a daily dose of glucocorticoids compared to those receiving stress dose steroids preoperatively. The recommendation is basically to use the usual dose of glucocorticoids or prednisone less than 20 milligrams per day rather than the stress dose with regards to infection risk. In terms of the DMARDs, non-biological synthetic DMARDs are recommended to continue at the time of surgery since it was shown that the risk of infection is not increased. Perioperative continuation of DMARDs also decreases the risk of exacerbation of the main disease after the surgery. In terms of systematic reviews and meta-analysis of biologic DMARDs, it revealed an increased risk of serious infections in some studies. Most commonly, the respiratory and urinary tract infections, skin and opportunistic infections are developed, including hepatitis B and C, TB, and various fungal infections, such as histoplasmosis. All current biological DMARDs should be withdrawn before the surgery, and it is important to schedule the procedure after the active period of these drugs. So in terms of anesthetic considerations, these are the what is listed here are the common issues that we look into prior to giving anesthesia to these patients with ankylosing spondylitis. First, the airway can be challenging to deal with. Okay? Number two, positioning issues, especially if the patient will be put in the prone position, considering the possibility of a restrictive lung pattern of breathing. Hemodynamic concerns may be due to chronic steroid use, or there could be cardiac involvement in this patient with ankylosing spondylitis. Hydration status, because most of these patients are elderly patients, which may have metabolic issues as well. Pulmonary, cardiac, renal comorbidities are quite common. And of course, with the intake of multiple medications and the effects of drug interactions with the anesthetics will definitely be seriously considered. So in patients with ankylosing spondylitis, and if there's involvement of the cervical spine, we have to plan out how we can intubate this patient comfortably in such a way that we might have to do an awake fiber optic intubation. So it can be done orally or even nasally, depending on the situation. So in terms of anesthetic management, in conclusion, proper perioperative management consisting of preoperative patient planning, as well as intraoperative, postoperative patient monitoring and care are definitely required. Further investigations are needed to build up a reliable evidence-based strategy of effective perioperative management of ankylosing spondylitis patients undergoing spine surgery. Thank you very much for listening, and these are my references.
Thank you, Dr. Geraldine Jose, for that lecture. We hope you're still online so that